Okay, one of the questions we get a lot is, well, Dr. Rutledge, if you're saying the MGB is so good, why aren't other people doing it? And the answer is other doctors are very worried about one particular problem: bile reflux. They say that when you do the loop connection that we use in the MGB, that bile reflux is going to be bad, devastating, scary, cancer is going to form, all kinds of really awful, terrible things. But it's interesting that there aren't other doctors in America who are opposed to that loop type connection when we do it every day as general surgeons for gastric cancer. So in other words, the loop connection that's used in the MGB has been used for 100 years, since about the 1895 when Dr. Billroth invented it. It's done about 16,000 times a year in the United States. It has a very good track record, and it's used in the United States nowadays and around the world for ulcers, gastric cancer, gunshot wounds, and trauma. And as I say, it's done thousands of times, and there's no wellspring of anti-Billroth 2 loop surgery in the United States or around the world. But something happened about the Billroth 2 in 1900 and then again in 1965. When the first Billroth 2 was invented, it was done in the early days of surgery, actually before doctors routinely used gloves or masks. So it's been around a while. When they did it, they were trying to get in and get out and do little kinds of surgery because mortality rate and infections were quite high, and so they did little surgeries and got out. And it was very successful. And as time went on, as we learned as surgeons to use antisepsis and gloves and things like that, we started to do bigger surgery with it. And as we did, the loop connection, which was done down low in the stomach to get a little tumor out or treat an ulcer and get out quickly, we started to take out more stomach, bigger chunks of stomach. As we got close to taking the entire stomach out, the loop connection was high. Not down low where it started, but high near the esophagus. Those patients did terrible. A loop down here, pretty good, not perfect, because it has some complications. The biggest one is a marginal ulcer. But down low, pretty good. Never, ever can you put it up high, because those patients, we found about 1900 to 1910, get bile into the esophagus, bile reflux, and do terrible. Down low, they do pretty well. Not perfect, but very well. And our data shows that. We've got 5,000 people over 13 years, and now other doctors around the world are adopting it, but American doctors are still thinking about that bile as a concern. And what we learned in the early 1900s, down low, okay, up high, not okay. All right, now let's go forward to the 1960s, when a very famous doctor invented bariatric surgery. In other words, somebody came up with the first idea to do weight loss surgery. A wonderful doctor, and his name is Dr. Mason from Iowa. And he said, gee, we're seeing these people who have Billroth 2s. I think I'll cut off the stomach and do a Billroth 2 loop, and I'll call it the gastric bypass. And he made a little tiny stomach pouch so you couldn't eat much, and he put the loop up high. So what do you think happened to his first patients in 1960? He repeated the mistakes done back in the 1900s, and those patients immediately had trouble with bile, so he converted his first surgery to the Roux-en-Y. And now all bariatric surgeons believe loop bad, Roux-en-Y good. And the Roux-en-Y does protect you from bile reflux if you have to connect up high. On the other hand, in the United States and around the world, every day surgeons choose to put a loop to connect to the stomach, never up high, because we've learned that's not right, but down low all the time. So gastric cancer, ulcers, and things like that. So when I did the first MGB, I wasn't doing anything different, but I connected the stomach to the bowel down low. Okay, but very good, honorable doctors in the United States and around the world go, Yikes, because we learned in 1965 you can't put a loop up high. But they didn't get the high part. They just, you can't do the loop. So not bad doctors, but they say, gee, Dr. Rutledge, he can't learn anything. You know, blockhead, because we fear this bile. We saw it in 1965 and you can't do it. And they left out the part that as general surgeons, as a trauma surgeon, for example, as a general surgeon, I all the time hooked a loop to the stomach, but I did it down low. Okay, but it's still okay for doctors to fear that, and now we are 13 years into my experience, and other doctors around the world who weren't quite as rigid in their beliefs have started doing the MGB. So not just the controlled randomized prospective trials in Taiwan, but now there are MGB surgeons in England, there are several in France, including a group, Dr. Chevalier at Paris, and this is all on our website so you can click on it. Surgeons in Austria, Spain, Germany, Rome, Sicily, Lebanon, Israel, India, Hong Kong, Australia, and Mexico and South America that are all doing the MGB, and they have reported their results. Now those results that they report are not level 1 evidence. The level 1 evidence, the most exciting, most valuable stuff, is from Dr. Lee's controlled prospective trials. But now, doctors who had a very reasonable concern, they were worried about bile. Bile, 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 bile. They're very worried about that. Now we're finding it's not too big a problem. But let's go another step further. Imagine, God forbid, that some of my patients suffered from terrible bile. You know, and there's that picture of Edvard Munch. I have the feeling of my doctors who are critical of the MGB, that they're like this, oh, bile. It's nice to know that in about 15 to 20 minutes, the MGB can be revised. So if, let's suppose I was mistaken in some, or even all of my patients, we haven't seen that. We've got over 5,000 people for over 13 years now, and we don't see bile as a big problem. We do see it sometimes, and we treat it as if it were a gastric ulcer. But let's suppose that terrible problems happened in my patients and they were suffering bile. You know, I got phone call. Suddenly my phone started going off. Dr. Rutledge, this is Susie in Idaho. I've got bile. And I'm Betty in Washington. I've got bile. And I'm Tom in Maine and I've got bile. Well, the nice thing is we could easily revise that. But my experience has been, and the other doctors who are reporting, is that the fear, and the reasonable fear of the other doctors about bile seems to be not a big fear. So it's a really good question. We just don't see much of it as a problem. Now there's one more little trick to it. Some doctors have believed so strongly that bile is going to be a problem that when they see one of my patients with an upset stomach or burning pain, they operate and turn them into a Roux-en-Y. Yet, I think I was kind of telling you, I see lots of my patients. I've never had to revise a patient for bile except for 3 times out of 5,000. So we have 2 people with biases. The doctors who do the Roux-en-Y say, aha, the MGB is bad and going to have bile. And they see people, and they've actually written a paper saying, aha, Dr. Rutledge is wrong, he's fibbing or something like that, because we're seeing it and we've had to operate on these people. And they talked about 12 people in North Carolina that they had seen. Yet I've got 5,000, I say I don't see it. So this is subtle, but I'd like to explain this. If you have an upset stomach or burning pain, you might look inside and you see it red or swollen or ulcerated. And ulcers happen in 5 to 10% of our MGB patients and 5 to 10% of Roux-en-Y patients. If a Roux-en-Y doctor sees one of their patients with an ulcer, they say, acid, and we have to treat it with an antacid. If they see an MGB patient, they say, it's bile, and we have to do a Roux-en-Y. If I see an MGB patient with an upset stomach, the first thing I say is it may be acid, and I treat them with antacids, and in 5,000 people, hundreds of people with upset stomachs, We treat them with antacids, and they seem to have gotten better. They don't need a Roux-en-Y. Now, my patients can always choose to have a Roux-en-Y if they want, but I don't think in general it's necessary. But there are some doctors who started off with a bias, bile is dangerous and bad, and then they see one of my patients with an upset stomach, and you will see some bile in there, and they say, aha, and they operate and convert them to a Roux-en-Y. And so actually in our pre-op permit, we tell you that. We say, you know, if you go see somebody with an MGB and say you've got an upset stomach and you're irritated and all that, you're likely to have a doctor recommend you get converted to a Roux-en-Y, which I'm not opposed to if you want to do that. But what are the negatives of a Roux-en-Y? Much higher death rate, much higher complication rate. So if you look, as we talked about in health grades, and look at Roux-en-Y programs, much higher death rate, much higher complication rate. Plus, what about a Roux-en-Y that fails? Can you revise it? Well, to get an answer to that, let's think of every national celebrity that you can think of who's had a Roux-en-Y. I'll tell you the ones I can think of. Carnie Wilson, kind of gained a lot of her weight back. Roseanne Barr, gained a lot of her weight back. Al Roker, looks like he's kind of putting some weight on. You may not know, but there's a football coach, or was a football coach at Notre Dame by the name of Charlie Weiss. He had a Roux-en-Y, has gained all of his weight back. Okay, those are all, you know, pretty well-off celebrities, and financially they could go and have a revision to fix their failed weight loss if they wanted to, couldn't they? I would think. But they're not, because most Roux-en-Y doctors will not do a revision. And there's a good reason for that, because it's extremely dangerous and deadly. Now, God forbid, as we talked about, if your MGB has problems, a revision's easy to do. So Roux-en-Y, first of all, everyone I can think of that's a famous Roux-en-Y patient has gained their weight back. I don't know, maybe you can help me out. Does anybody know of a successful celebrity that's had a Roux-en-Y that's kept their weight off? Isn't that surprising? In other words, here is the, quote, gold standard. Have you heard that? The Roux-en-Y is the gold standard. So the gold standard, there's not one celebrity that I can think of that's a success. Then I can think of a lot of failures. There may be some successes who are hiding it, you know, but the Roux-en-Y, in my experience, because, you know, I have a website, I get emails and my staff get phone numbers every day, phone calls every day, and they call me and they say, I had a Roux-en-Y 5 years ago, I've gained all my weight back, can you help me? And I answer, no. I don't think I can safely revise a Roux-en-Y. So when you choose your surgery, one thing to consider is it revisable? And the Roux-en-Y is possible to revise. There are a few doctors who do it. Most doctors, if you call them up on the phone, like you're doing research, just for interest, call and say, I'm Mrs. Smith, I have a failed Roux-en-Y, will you do a revision? You know what your answer will be? Click. Because it's very hard to do and very dangerous. Now the MGB, on the other hand, easy to revise. It's not that we don't have failures. We have patients who lose too little and lose too much. We've had both of those things. We have other problems. I mentioned there are 3 people that had true, I think, bioreflux that needed to have a revision. And revision's about 30 minutes. Revision of a Roux-en-Y, deadly.
Can I ask a question with your...
No, she's got her... No, I'm just kidding. No, she gets all the questions. She'd run her pad.